Okay, well, hey, it's another episode of let's talk healthcare or health tech, right? And today we have Pete Celano along with Larry Trotter, my inimitable co-host, and today we're going to talk about LiverRight and what you've been doing and what you've been up to. And the way we got started, the way we met is you and I were talking about ExpertScape, my thing,
Right.
and it got into a very interesting conversation. You had some good advice for me and for the company at the time. And you were at MedStar then. And so I thought, and now you're on the kind of the other side, and I
Right.
thought it'd be good to have you on to chat. So why don't you start, Pete? Why don't you start by kind of telling us a little bit about LiverRight, and then we'll dig into it.
Yes. Thank you, Brendan and Larry. Healthcare is going through radical disruption these days. It started as a function of COVID, got accelerated by the push to value-based care at long last after decades of talking about it. And now it's in full flower. LiverRight is one of many disruptors with a capital D. We're trying to change things up. I'm sure you'd agree in American healthcare, it's been principally fee for service. So we wait till somebody gets sick, we patch them up. Quite frankly, the sicker they are, the better on some level, because you can charge more to patch them up. There's no real economic incentive to find disease states in early stages, although, of course, healthcare folks are well meaning and they want to, but without the economic alignment, it can be hard. Plus, there was a little thing called AI that hadn't been invented that makes it now so much easier. So, LiverRight is a classical player who's attempting to do something big. We're not different than the three unicorns in CKD, right? In chronic kidney disease, you have Somatis, Strive, and Monogram. They're three of the 400 disruptors across every specialty, including primary care and urgent care. And in America today, 42% of adults have liver disease, mostly undiagnosed.
Wow.
We used to demonize liver disease, so people aren't that hip to it. But now, thankfully, we don't demonize. And of course, it's metabolic in an era where there's GLP-1s. So before us, and I'm sure players like us who will come in, we just happen to be first, it's highly likely you'd find out you have liver disease late stage, F3, F4. It's not reversible then. You could be on your way to liver cancer or a liver transplant. We're trying to swing that pendulum to the left. So that's a function of virtual plus AI plus what we call utilization management. And we're up in all 50 states with our own hepatologists and hepatology APPs. And we see patients same week via the magic of telemedicine.
So is it more that what you're doing is pushing forward the availability of this sort of standard diagnostic tools, or do you have some new kind of solution to diagnose earlier and more cost effectively?
Yeah, you ask a great question. So in the set play in the playbook of specialty clinics who are applying telemedicine while honoring the in-person pieces, you always compress access. So in hepatology, there's 800 hepatologists in America. So you're going to be months out, and it's the in-person model. Hospitals are mostly back to in-person. Conversely, we're same week video visit. So that's great, but it's not enough because you're out to actually change the outcomes and cost curve. And just doing virtual doesn't really do that. So it's the application of AI that means we can make outcomes far better. And for the payers and the patient, copays costs 40% less.
Okay. And so who are you? You came from the hospital side of things. Who are you selling to now? Who's your customer?
Well, we partner with hospital systems and independent GI practices, but very importantly, we have our own direct clinic. You have to have the swagger to do it yourself before you ask partners to do it. So today, LiverRight's up in all 50 states plus DC. Anybody can book an appointment same week. They'll see a nurse to start with us. We're very nurse heavy, but we have docs as well. They supervise our nurses in every state. We take insurance,
Yeah.
and
Okay.
we happily manage them directly, moving them off for imaging and oncology, et cetera, as needed. However, the problem is it's very hard to scale because we're an unknown brand, and we know the power of the hospital systems, the independent GI practices, and the essential in-person pieces that they already own. So we offer to hospital systems to become their virtual HEP front door, and that's good for them because they're addressing those patients. So it's equity, it's
Yeah.
competitive advantage. versus the knife fight in their geo. And there's big downstream revenue. So more liver patients means more labs, imaging, biopsy, cancer, 340B, clinical trials, and if they have liver transplants, those as well.
So you're actually like a, not to oversimplify, but you're kind of lead gen for the hospitals.
Yeah, but we'll carry the patients through to longitudinal care. So we'll always play by their rules
Okay.
for the road. If they have
Okay.
2 heps and those heps need to be fed, we'll triage the patient. And if they're low acuity, probably we'll just keep them under their
Yeah.
brand. It's
Yeah.
all under their brand. They built
But
the
it is.
payer.
Okay.
Yeah, it's all a white label deal. And maybe the high acuity cases go to those 2 heps until they're full, at which point we should keep them longitudinally. So we can do triage, diagnosis, and care. And it's a rare deal where we'll be handing them all off post triage. They don't have the capacity.
Yeah. Okay. That makes sense. And so your customer is that you're selling to the hospital.
Yeah, the best. I came from, as you pointed out, a big hospital system. They have terrific geographic presence, deals with payers, negotiating leverage, et cetera. So the best way to help 100 million undiagnosed Americans for liver disease, now that liver disease is having its moment, is through the lens of hospital systems and independent GI practices. So get this, people say, how could there only be 800 hepatologists in America seeing 100 million people? And the answer is we don't allow, even today, a hepatologist to just become a hepatologist. They have to become a GI doc first.
Okay.
So you have to be boarded in GI before and if you might do a second fellowship in hep. And think about it. If you're both, you're probably going to be scoping. It's the most lucrative thing a GI doc can do.
Yeah.
So we encounter 3 types of hospital systems among the 600. Of course, the 120 that have liver transplant centers, they have hepatologists, but they're very focused on transplants. So they don't want to do everything else. They want to operate at the top of their license, the greatest cliche in healthcare. Then we have systems who move patients to GI docs. It's great, but GI docs aren't as current with hepatology and they're reducing system revenue. So that's not a good idea.
Yeah.
And then finally, there are some systems who simply say, we got nothing for you, liver disease patient. So we'll play across any of those 3.
Okay.
So Pete, I have a question. How did you all navigate the telemedicine regulations that expired, and in general, because I know it can make providing care very complex, right? Because each state has the different requirements. How did you navigate that with your private clinic?
With extreme anxiety, Larry. As we waited for that, we heard that it's highly likely they were going to continue telemedicine. It's knit into so many clinical entities. And hospital systems are even for it because obviously they use it to expand their catchment area. It's so key for the rural indigent patients. You know the story. But had that gone the other way, it would have been bad news for all of us. But think about the all of us. There's 400 national virtual clinics. They're doing a lot of work across America in every clinical entity. Not that we just loud unicorns, but there's so many. Kidney, I mentioned 3. In MSK, there's 3, Hinge, Sword, and Kaya. They've become very mainstream and they don't fight hospital systems. They partner with hospital systems. So I was nervous until that good news, and that good news has to obviously keep coming. It would astonish me as a healthcare veteran if they unrang that bell.
Yeah. Okay.
And is there any other way to make it more efficient than having a provider in each specific state because of the whole cross-border thing? Or is there an easier way to do that, or do you just have to have
a
provider
license? You ask a great question. I mean, when you wonder why there's 400 virtual clinics, there's 3 reasons. One is Americans love convenience, and we learned that it works well during COVID, even for elderly people.
I love it. I love it.
It's powerful. But there's times when in-person is so much better. I'll comment on that in a minute, though, about RPM, if I can wedge it in. So that was one giant tailwind for disruptors. Of course, venture capital availability was another, but let's talk about that another time. The second is you could up-license docs and nurses to all 50 states. So, for us, we have about 40 providers now. On average, they carry 5 or 10 states. They need to kind of know the geography, which would be hard if it's more than that. And it's easy for docs because there's a compact. So now imlcc.com allows docs to blithely up-license. Of course, we cover the cost. It's like a college student applying using the Common App. So they've removed a lot of the friction. But by far, and America generally doesn't know this, the greatest tailwind for virtual clinics has been radical health record liquidity. So Larry, let's say we took you on at LiverRight and you are F3. So you're not quite on the transplant list, but you're very sick. You have a lot of story, and it's essential for us to learn that fast. And rather than ask you a few hundred questions, we say, Larry, can we pull the totality of your retrospective and prospective EMR data? Would that be cool with you? And you'd say, yeah, but I don't know where I've been or where I'm going to go. Yeah. And you don't need to. We can get that. So that becomes the essential red meat for AI, where we're being very predictive, as we'll probably talk about today.
Yeah.
Yeah, and being able to get those records from essentially my medical history trail, right? You say you're able to find that. Wow, yeah, that's big.
We pull it all. Yeah, so I think in the future, you're going to tell friends if they call you up and go, hey, Larry, I got to go to a doc. You'd say, I don't need to know the details, but get AI with that. There's a volume of story, friend, about you, past and present and future. And they should contemplate that with AI as they treat you. You wouldn't get on a plane if the pilot didn't also have autopilot. So AI is circumscribing all of healthcare, and it can radically bend the cost and outcomes curves.
But still, at the risk of sounding cynical, it's still this cross-state restriction is arbitrary.
Yeah.
And it doesn't, there's no value add. It's just it's a blue law.
Right. It's like taxi cab medallions in New York City before Uber came along. But it's not hugely expensive. You know, I've met plenty of docs who themselves, because they work in the virtual realm and they're working probably with multiple protagonists, they carry 50 states, and it's, $250 per state per year. So it's not ginormous. It's a bit of paperwork, but IMLCC for docs makes it easy. Nurses don't yet have a comp.
And I think,
but if it's $250 a state per doc, and so it's still, if you do 10 states, it's $2,500 a year. And what does that get?
We have no bricks and mortar, Brendan. So, as disruptors, let's compare and contrast. We're not competing with hospital systems. So if they're sitting on acres of real estate in a time where virtual and AI are coming along, probably to reduce the number of in-person encounters, they're probably AI light. They'll get there. We're AI heavy. I'd rather be us. So our buildings are investing in AI.
Yeah. Right.
So Brendan, are you saying you don't think there's any logical reason behind the whole cross state regulation protection? You just think it's
protectionism, and it's because and what it does is it probably delays best practices. So because if you could get a Mayo Clinic doc to deliver care in Wyoming and Idaho, then it would probably elevate the behaviors and the protocols and so forth and the practices for any doc that's in Idaho and Wyoming, who probably don't have any hepatologists.
So and I agree, Brendan. The only one reason, guys, correct me if I'm wrong, I think that those regulations are in place is because when it comes to, let's say, HIPAA, right? Each state has certain requirements on how long you need to keep patient records and that sort of thing. That's just one example. So I think that's why they have those regulations in place, because everybody has different states has different regulatory requirements. So if you start doing the cross state thing, then a doctor in Wyoming might keep your records for 2 years, but no, your patient that lives in California, you should have them for 10 years. So I think that's one of the reasons, things like that.
Which is another example of protectionism, if you ask me. Because why should you have different regulations? I mean, especially I don't know if you're aware of this, but the states on the Eastern Coast tend to be rather small. Some of them you can throw a stone across. So why is it Rhode Island and Connecticut? Why would they have different regulations? We're going off in a rat hole, and that's my fault. But Connecticut and Rhode Island, they butt up against each other, and they probably docs on the borders have, so. It's just sort of these are ridiculous constructs, if you ask me.
Yeah, we could definitely go down this rabbit hole, but all right, yeah.
So anyway, Pete, how do you sell? Since this is, this is about a lot of this about sales, so how do you sell to a hospital? What's the approach that you take?
Well, this is a challenge, right? When I was in innovation at MedStar, it was pre-COVID, and I might get 5 pitches a week, but I think they're getting 50 now because there's so many disruptors, and we all know how relentless LinkedIn can be, and email. You can automate all that.
Yeah.
So in a way, it's
It
great
works.
to be them. Yeah, it works. They're hit with a bewildering set of pitches, great pitches, right? In many cases, and they have to sift through that. So it's become increasingly hard. My prevailing theory, don't laugh because I just have talked about telemedicine, which is clearly virtual, is let's return to face-to-face. So to me, the ideal model is in each geo, and for a player of our type, there's either 4 or 8. It's not like you need to put somebody in every state. Planes and trains work well. Is you find somebody who knows the hospital systems and payers and ACOs, depending on your verticals, in a geo. So we've been talking to a gent who is in the Boston area, and he knows everybody.
Right.
So it'd be reasonable to imagine that while the innovation leads at the Brig and Springfield Hospital in Western Massachusetts are inundated with cold calls, cold emails, cold LinkedIn's, he's able to call up the Brig and say, "Hey, remember me from X? Any chance I could come talk to you about virtual hep?" So that's the antidote. It must be great to be a salesperson today, a biz dev exec who knows a tight geo. Conversely, if we met a BD exec who was in Boston but moved to LA, what are we going to do with them? They don't know the territory.
Right.
So got to get face to face, and face to face is kind of back, right? People have Zoom's traumatic stress syndrome. So a lot of docs and execs actually want to get away from the computer. So that's my asynchronous thinking, even though I'm in the business of virtual.
Yeah. And then once you get that conversation, what's the message? What's the kind of approach that you need to take? You get in front of the right person, chief of medicine, or is that?
Well, docs have power, but they can't do the deal by themselves. So your choice is to kind of go through innovation, clinical transformation, chief strategy officer, service line leader, and that's a civilian, right? An MBA or MHA type.
Right.
But they then need to get a doc.
Talk slower. Is that what you do? Talk slower and more pictures?
Yeah, that's right. A lot of spreadsheets, really. And I'll get to that. It's an economic sale at some point.
Yeah, right.
Alternatively, you can get a doc, and if they have interest, they can almost force the innovation group.
100%.
It tends these days to be about 3 things. You got to talk competitive advantage, because the truest thing I said at the top of this podcast is it's a knife fight in every geo. Healthcare used to be very genteel, but now they go at each other in this pitched battle for market share. So if you can offer true competitive advantage, that's interesting. 1 of 3. 2 of 3, equity has become a thing. It's long overdue. But now it's obviously the right thing to do. Healthcare is very left-leaning to help patients with X who aren't currently getting X. And you can also make that valuable with your payers and with the state Medicaid organization. Of course you can. So when you look at the rise of a player like Pomelo Care, POMELO, virtual maternal fetal medicine, they really ran hard at equity because 40% of babies are born under the Medicaid insurance.
When you say equity, you mean you're granting equity to the early adopter?
No, doing what's right. Making
okay, all right,
equitable.
Yeah,
because CMS and other government agencies, but especially CMS, which has been so smart as to driving us to value-based care, believe it's immoral, unethical that we 3 get all these cool new innovations, but not indigent patients, rural patients, elderly patients. They're out to change that. But the third is money. So here's where
ROI.
Yeah, gotta be money, ROI. Like, you take a hospital system that's doing $5 billion a year, they don't care about $50K more in revenue per year. So you actually have to say with a straight face, if it's true, we can drive you by year 3, 25 million in incremental revenue.
Yeah.
Why would they care? So you think the problem is, as a salesperson, you might think the problem is getting them to like it. The real problem is getting them to up prioritize it because they're hit with a giant set of solutions. So I get calls
100%.
sometimes from entrepreneurs, and I tell them, what you're doing is great in healthcare, right? But it's not big enough to get their attention. Make it bigger, make it grander.
Yeah. Yeah. Okay.
Mm.
So, all right. So switching to kind of the bigger picture, before you got on, Larry and I were talking about open evidence and their latest funding round, and I guess they're now the highest valued healthcare play. If you take the open AIs
Right.
and the kind of the core platform products out of the equation, whether that's true or not, like what, just in a general sense, you come from the innovation side when you were at MedStar, where do you see AI going? I mean,
Yeah.
like, what's the big picture?
It's washing across everything. Not that I'm a Lilly MBA type, but when I get calls from friends who are going for imaging, radiology, I always say, get AI with that. Right. So the FDA has cleared a couple hundred modalities where you get, say, for your heart, a CCTA. That's like an MRI of the heart.
Yeah.
And behind door number one, you could count just on the human radiologist. They're great. They peer into those black and white dots on their screen.
Yeah.
Must be a hard job. Behind door number two, you get them an assist with AI. Clearly Health is a great example. CLEERLY. It runs over the top of the CCTA and is more discerning than a human radiologist. So always get AI with that in imaging and really across healthcare.
But what
you bring
one,
up go ahead.
If I could just jump in on that. I mean, the fascinating thing about this is with AI, in some cases, some of this has been around a lot longer than those of us on the outside are aware. I mean, imaging AI has been around because it's a different kind. It's not LLM AI. It's pattern matching, and it's image processing. It's a different kind of more machine learning. And so, I mean, Larry, you may remember CuriDX was on, and they've been working in this space for a while. In terms of solutions that are AI based, but they're of a different ilk. And so some of this has been brewing for a number of years, and we just those of us on the outside weren't that aware of it. I mean,
but to the FDA's credit, and I'm lauding our government agencies today, they have vetted these, and they're unimpeachable, and they get CPT codes, and you can charge for them. So let's take a look at Clearly Health. The CPT code's about $900. The payer covers about $900, and so you'd be $180 as your copay, and it avoids stents before their time. So quite understandably, if the human radiologist can only discern so much, we err on the side of caution, and Joe gets a stent.
Yeah.
But clearly, don't hold me to this exactly, they report 35% fewer stents, not because they're trying to save money with the stent manufacturers, but because they're not merited, maybe ever, or at least not now. So there's a powerhouse ROI for these solutions. No woman should be getting a mammogram today without AI running over the top. But your point about open evidence is really interesting. There's a seminal article in the Wall Street Journal a couple of weeks ago about D2P, direct to patient. And that's pharmas realizing that there's no longer as good a value in hiring an army of pharma reps, right? Remember pharma reps, they would go around to catch docs and nurses for 15 minutes in the hallways. And they'd show something on their iPad. They had to be the greatest speakers across, in terms of brevity in the history of the world, right? Netting stuff out. But two problems. One is during COVID, we made it hard for outside people to get in for good reason, inpatient or outpatient. And secondly, the doctors derisively now say, we have a really good way to get information about a new drug or a new diagnostic. It's called the internet or mobile, right?
Yeah.
Now, open evidence took the old model up to date, was the tool most docs used, and they AIized it, of course, making it better. So the sea change that's happening now is you'll go to a website, a pharma site for their drug, and it'll have a button on there, connect to care. Because think about it, if you're at a medical website, a drug website, you're not there just to read about the horrible side effects. You want it. You want to see if it's for you. Would it help you?
Oh yeah, for sure.
So they're connecting mostly to virtual clinics, because that just makes sense, but also in-person care. And In so doing, that just tells you further that things are changing. The pharmas who used to employ those armies of reps now realize they should move the spend online, right? And probably the virtual clinics, I say this hopefully for LiverRight, have the most to gain from that. And yeah, docs aren't seeing pharma reps in the hallways. They're using open evidence to figure out what's current, and they are slaughtered with data every day. Like if you're an onc, somebody told me to stay current, let's say you're a breast onc, you have to read 300 journal articles a month. Good luck with that. But what if open evidence nets it out for you? That's why it's so valuable.
Yeah. Okay. That makes sense. So, Larry, anything else you got for him?
No, man, that was a lot to take in. I
So-
took in a lot.
So you touched on this early about value-based care. Like everything's basically fee for service, more or less. You know, with there's a kind of an icing of performance-based, you know, motivation and the like in some of these cases, but mostly it's a lot of fee-based, you know, fee for service stuff. But is value-based care? Are we getting there, do you think?
Yeah,
do you think that's
it's
really a
growing
thing?
very rapidly off a small base. Let me once again extol the genius of CMS. So they put in the ACO model right now, and it's 12th year. That's at-risk primary care. Think about primary care a decade ago. They must have looked at it and said, we have hyper specialization in America, and a patient can get straight to a derm, straight to a cardiologist. We don't have like advanced diagnostics that are reasonably priced that could be put in primary care. And the primary care docs aren't having much fun. They're not doing fancy stuff, right? They'd probably like to do fancier stuff, get into certain specialties, at least low to mid acuity. So they invent the ACO, and it's been a total and complete rocket ship. Now CMS wants every Medicare beneficiary in at-risk primary care, think value-based care, primary care by 2030. And if you doubt what I'm saying, look at Oak Street. Why did they sell for $12 billion to CVS? Because they became a very deft practitioner of advanced primary care. They made much more money because of the value-based care rubric than they would have in fee-for-service, and they deserved it. They drove better outcomes. So primary care, check. Now you think about specialty. Is CMS rolling out value-based care specialty models? Yeah, obviously they are. Look at CKD. CKD is the greatest example of the genius of CMS. It used to be highly likely that if you had chronic kidney disease, you'd find out about it in stage 4 or 5. It goes CKD 1 through 5. Straight to dialysis for you, Brendan.
Yeah.
But
right.
now, as a function of SomatoStrive and Monogram, especially, and an interesting home urine test, America is being diagnosed and treated. We say trapped and treated at CKD 1, 2. Payers have saved billions. Patients have avoided dialysis. And there's a formal CMS value-based care kidney program. There's one in cancer. There's one in dementia. I could go all day. So make no mistake, if you are in healthcare today, you better have a value-based care strategy. It's coming. And the other thing I'll tell you, you know, I was in cardiology for 4 years, and people would say to me, you couldn't have been doing value-based care because there's no formal CMS program. But you can do value-based care deals with payers without there being a formal program.
Right.
Well, before there was a formal kidney program, the players I just mentioned were doing value-based care deals with payers. So you turn your head from AI and value-based care in America today at your peril. Of course, they're tightly linked.
Yeah. So maybe that's one of the takeaways for anyone that's in this, you know, a health tech company that's looking to sell into health plans, health systems, and so forth. And, you know, or is that put a value-based care message together around whatever it is you're doing. Yeah. So that's very helpful. So, well, we're coming up against the hour or the half hour. And so, Pete, again, I appreciate, you know, we appreciate your taking the time to chat, and this is really helpful. And you know, I wish you the best of luck with this, and I'm hoping I don't have to ever use your application.
If you need it, Larry, Brendan, we're there for you. Great to chat. Healthcare used to be so sleepy, and now it's popping. So it's fun.
It definitely is.
Yeah.
All right. Well, very good. Well, thanks again, and we'll see you on the other side.
Thanks, Pete.